is going to be on the screen. All right, we're going to make this hybrid thing work, guys. These guys asked both of us to come and talk about what it is like growing up in an ICU. We know that young children with MSMDS spend a lot of time early in life in the ICU, and so we're just going to talk for a few minutes about some general considerations with care coordination when your child is in the hospital, and hopefully some of this also applies to when your child is at home.
Mm-hmm.
Okay. I don't have any conflict of interest. Dr. Carroll does have some respiratory device licensing involvement, but nothing that we're going to be talking about today. Do you want to start, Ryan?
Yeah, I'll jump in. Hi, everybody. Just really happy to be with all of you. Thanks, Jess. Yeah, it's very likely that some of your children and loved ones have spent some time in the ICU, if not considerable amount of time in the ICU, and maybe you can even feel like you've camped out there and laid claim to some real estate. And I think because of that, and I'm sorry we have to meet sometimes, pre-op, post-op, or for other reasons. And I do think the ICU setting can provide a lot of support, even though you want to get out of there as fast as possible. I think because we get to know you and your family and your child at a very critical juncture in your path and narrative, I think we can play a vital role, not just in that moment, but after that. And it's possible that children will sometimes see us several times in their young lives. And because of that, we actually get to know each other. I've had the opportunity to get to know Raceland and Dixie/Lydia and Warren and Warwick. It's been a real privilege. And I think we've been able to connect at different times and talk about long-term goals, et cetera, which we'll get into in a little bit. I guess we were just wondering though, within the ICU context, usually the intensivist or the complex care coordinator team are the ones who coordinate your care, but who does it outside of the ICU and how is that integrated into ICU care? We're sorry to bring up Tom Brady here.
Yeah,
Or
I'm also sorry to bring up
or your
parents
guy.
here.
Sorry.
So, like Dr. Carroll said, sometimes this person is an intensivist, and the intensivists are really great at coordinating care because they are thinking about your child as a whole person, and they're the people that are talking to all the specialists and then kind of coming back and deciding what to do. The limitation of intensivists, though, is that they are not there when your child goes home. And so that's kind of where a team like mine comes in and helps them with the transitions from the hospital in and out of the hospital and helps with sort of bridging those transitions when you're at home. I work in a complex care program. A lot of hospitals have complex care in pediatrics now, but not every hospital has it. My program is made up of providers, nurse case managers, care coordinators, social workers, and we all get to know our families really well. We chat with them every month. We check in and say, are there any issues that we need to kind of address before they happen? Any surgeries coming up that we need to get the ball rolling and plan for, or procedures that need to be coordinated to minimize the time that the child is under anesthesia? And so I'm kind of that person that I call myself the captain of the ship frequently as kind of this person that's able to bridge pediatric care in and out of the hospital.
we thought, so there might be some context. So the major concepts we wanted to go through, Dr. Schnell and I thought over the years that we've had the privilege of engaging with your loved ones and with the Acta 2 team is this concept of maybe a primary PICU provider, P3. We're just coming up with this name. This doesn't exist. We're happy to start a trend. The concept of what matters most to you, that movement, which is a national movement, that's found its way into several sectors of medicine, including the ICU and ongoing care. And then highlighting the concept of the care plans that can be embedded into EMR, the electronic medical record, or for a lot of us, it's Epic. And that utilizing that tool as a consistent mechanism by which to communicate care plans from provider to provider, and wondering if anyone has had experience with that. Well, but we'll go through those one by one. Dr. Schnell.
Yeah, so I brought this up to Dr. Carroll. I think some hospitals around the country are starting to formalize what we are calling the P3, or the primary care or primary PICU provider. So at my hospital, this is a few intensivists that are very good at long-term care, things like goals of care discussions and care conferences and getting to know families really well, who have been given some protected time, which is important in academics. It's extra time where they're not grounding as an intensivist, but they're just there to be there when their primary patients are in the hospital, which has been a really nice change for us, because as I'm sure everyone has experienced, if your child goes to an academic hospital, the whole team changes every week. And so we get in this situation where the new person coming on they got sign out on the medical stuff, but they don't really know you, they don't really know your child, they don't really know some of the like overarching discussions about the hospitalization. And if your child's in the hospital for a while, that might mean that you're sort of having deja vu, which is what this picture was supposed to show. When a new person comes on, it's like, we tried that already. We did that a few weeks ago. No, we already asked the GI team what we should do about this. And so the primary intensivist model is a concept that has an intensivist that their colleagues trust, but that person is kind of there to bridge the gap when teams change every week. And be that person that says, yes, we did already do this, or maybe that's the person that's calling Dr. Mussolino or Dr. Lindsay to trying to get some extra expertise and then pass that along with the people that are involved in the direct care of your child. My team can do a little bit of that, but my team also changes every week. So even though, I know my primary patients very well, the part of my complex care team that also rounds for a week at a time. And so the hope is that this would kind of get around that. And in my patient's case, that I talked about a little bit yesterday, there was definitely a time when this was incredibly impactful. It was a situation where I needed to bring him into the hospital for a very simple problem. And then when he got admitted to the ICU because he had a tracheostomy, and that's where all of the kids with trachs go in my hospital, people started noticing some other things that were just kind of weird going on. He was having some bloody rectal discharge. He was having a change in his trach secretions, and the intensivist really felt the need to fix everything else that wasn't really why he was there. And so he ended up getting a very comprehensive GI workup for this bloody discharge, and getting a couple of new diagnoses that then kind of set him on this alternate trajectory when the reason that he was having the bloody discharge to begin with was because of MSMDS and the poor motility. And So it was a situation where what we kind of came in to do kind of got derailed a little bit because intensivists that didn't know him very well started trying to find all these other things. And the longer he stayed there, the worse he got because you know you run an ICU in your home, and coming into an ICU, even with a nurse that has 3 patients instead of just one, you get behind on things. And so um it was a situation where I was hoping he would just be there for a day or two, and then things just kind of fell apart when we got there. And having a primary intensivist step in and say, actually that this is not normal for other children, but it's very normal for him, and we don't need to fix it, and communicate that with her colleagues to get everybody on the same page about that was how we got him out of the hospital and back home where he needed to be. So that's kind of one example of how this is really worked well for community.
And maybe for us at Mass General, it's not as deliberate. In fact, whenever I hear Dr. Schnell talk about her work, I always think about a gap, I think, in our own system that probably should have someone that we can call like that. I think it occurs in our ICU a little bit more organically, and in many ways, the intensivists that get to know a child are all um, it's just by serendipity, just how many nights or weekends or weeks you've been on service when that person's been admitted, and how well you've connected, et cetera, with the family and the child, and you get to know them over time. And I think in some ways, I've had the opportunity to be on service when Raceland has come in, or come in and check in when I see that he's on the ICU board. And we've had conversations with Warren and Dixie about just longer term concepts and questions about airway management, et cetera. And also just checking in with Warwick and watching him grow up and talking about some of the things that he's facing. I wouldn't go so far as to say that I'm the P3, or I'd be honored to be that if we had such a concept. And that's what I'm getting at. I think that if there could be someone who would consistently touch base in the ICU, or could consistently be part of like the care conferences, et cetera, I think that would be possible. Or maybe, as Dr. Schnell was mentioning, sort of a group of individuals who are available for that and understand the child's total picture and trajectory, wishes of the family, et cetera. Part of the organic aspect in our unit also is that Doctors Lindsay and Kanan and Mussolino are available and often check in as well when they hear one of the Acta 2 patients or MSMDS patients are admitted, and they'll often check in with us as the intensivists, or come in physically, or happen very much it's a very real reality is that one of them is probably on service, etc. But it would be nice if there was someone who was very consistent, can be called upon to help weigh in. And thank you, thank you, Dixie. I'm very happy to be the P3, and for Raceland, and and part of that, I think, as individuals, as parents, for instance, there's a concern: can I, um, could who can play that role? And as the intensivist that's on service right now, could they possibly would it be okay if this other intensivist that I got to know some months ago can weigh in? Because we've had all these conversations already. And I think that parents should be empowered to do so. But that isn't something that has been deliberately discussed, but I think it should be and can be. One way we have focused on this in a little bit in our ICU is Dr. Sarah Murphy is one of our neurointensivists and one of our pediatric intensivists, has a PACE clinic. It's basically a post-ICU clinic. And so after a family has been through the rigors of the ICU and have graduated, they follow up the PACE clinic. And there's a lot of conversations about, as well as with Dr. Wishart, with PM&R, so sort of rehab. and looking at some of the long-term effects of being in the ICU and the ability to re-enter into life, both psychologically, physically, mentally, and looking at what those new burdens might be. And so we do have
Right.
something like that in place. And so I just think this is something that I've had an opportunity to engage with a few other families that have come back to the ICU several times and play somewhat of a primary role with those families, even if I'm not on service. And I think that's important. It's just very organic. It's not very deliberate. And so I wonder, and I would hope that all of you, all parents out there would feel comfortable asking, could we just have one or two intensivists come in and help make decisions, not day-to-day decisions, but just when we're having longer term conversations, et cetera, and to check in, et cetera. I think that would be fine. It should be fine. But it would be something that the culture has to embrace within the culture within that ICU would have to embrace. So let's start a movement.
Yes. The next concept that we wanted to talk about is this concept of what matters to you, or at my hospital, it's called What Matters Most. It is a national movement in ICUs and also the regular hospital floors to just make patient care more family-centered. And so the way that it works at my hospital is this gets asked at the end of team rounds every morning. What matters most to you today? And then whatever the parent says gets written on the board in their child's room, gets written on the like clear glass door that goes to their ICU room. And then that is what the team, it may have something to do with the plan for the day, but what I've noticed is that often it doesn't. Often it's something more like, we've been here for a week, can we get PT involved today so that my kid doesn't get too deconditioned from being in the hospital too long? Or, his diaper rash has gotten really, really bad and it's causing him a lot of discomfort. So I know that ICU doctors don't care a whole lot about diaper rashes, but it means a whole lot to me to get this fixed. Can we ask the wound care team to come by? And so it's a way for parents to give input both into their child's like day-to-day care, but I think also into a lot of pieces of being in a hospital that doctors and medical teams often forget about and kind of get pushed to the wayside. So that's how it works for my team. It's a little bit different for Dr. Carroll.
Yeah. I I think so. This is something that was a big movement and it's still around. And as with most external movements, they ebb and flow a little bit with popularity. So I think this is quite popular a couple of years ago. One way that this is manifested in our ICU, excuse me, is is we have a child life and social work will sometimes put together a poster that's pre-printed and it's a template poster and it fills in and they fill in with the parents or the child themselves if they're old enough their name and their favorite color and their favorite dinosaur and embedded in that context, embedded in that poster is what matters to you or what matters to you most, and something that the family is interested in maintaining focus on. I think another way that it manifests we have little whiteboards in our PICU where the name of the child and the family's name, parents' name, and phone numbers are often written while during the child's stay. And then daily we change, or actually by per shift, the name of the physician and the nurse, et cetera. But often at the bottom is written a goal for the day. And sometimes those are medical goals, and sometimes they're not medical goals. And I think one thing that I really enjoy thinking about with children who are in the ICU is that there's a lot of machines, there are a lot of inanimate objects and wires and tubing, and the child can get a little bit lost in that morass. And one way we try to bring the child's anima, sort of the concept of who they are, their sort of in total is the family will bring in photos from outside and put them up on the wall, even for a brief stay. It often usually happens in the context of a much longer stay because there's time to do that. But it gives us a goal of we want to get back to that. We want to get back to where the child was healthy and playing at home. And as intensivists, it helps us remember that that's this child. This child is not an extension of Ohm's law and trying to keep pumps and tubes delivering oxygen and glucose, but rather this is a child as a whole, and they have siblings and they play, and we want to get back to that place. And so sometimes we do it through that aspect. And I think that's just an important part of the daily rounds, as Dr. Schnell mentioned, and probably could be a little bit more deliberate in the daily rounds about what is the real goal or what is the overarching goal. And so that with the forest and the trees are considered equally and not just all the trees that we love as intensivists to really focus on as just all the tiny minutia down to the pine cone needles. And there's a paper that often gets quoted when you look this up, What Matters to You Most, Barry et al. I don't know if I'd really recommend it. I don't know. It's just more about shared decision making, which I think we all do very naturally in the IC pediatric setting with family members and even children who are old enough. But it's something that this paper is more about adult decision making, so it may not be really applicable. But it sometimes it gets quoted in this context. But anyway, again, another movement that could be integrated into care and really helps us remember that there's a lot more to consider here than the pathophysiology of a child, but rather the whole child. It's important for us to remember that.
And then lastly, the last thing we wanted to talk about is just how to make the medical record work for you and for your child. This can also look different at just different institutions. Where I am, we use Epic, and Epic has this really nice thing called the care coordination note that is at the top of the kids' chart, no matter where they are. If they're in clinic, if they're at home, if they're in the hospital, if they're in the ER. This note is one of the only places in the medical record that crosses all of those different spaces, and it's where we choose to write the most need to know patients or things about our patients. So this is a snapshot from my ACTA 2 patient, and I actually printed out his entire care coordination note because there's a lot in there, just not necessarily the content, but just thinking about how to make contingency plans, how to make plans for if your child needs to go to the hospital, what are the 10 things that the hospitals most need to know. So we start with a one-liner that kind of has a little bit about the child and all of their medical problems. I also put some stuff, about family really wants him to stay out of the hospital. So before you recommend that he stay overnight, please call me and talk to me because this family already does a whole lot for him at home, and I don't want him to stay if he doesn't have to. And then there are a lot of things about what the child is like when they're healthy, and then what the child is like when they're sick. Just kind of this sort of high level overview of the most important things that you want the people to know. And some of those things are things in an emergency, things when they're going into a procedure that you want the pre-op team to know, medicines to avoid. And so it's a nice place where everyone can see it. And most medical records now have something like this. If it's not called a care coordination note, it might be called something else, but it's one thing to ask your medical team about. How do we kind of create this sort of shared plan, contingency plan, emergency plan document that lives where everybody can see it?
And similarly, this is with permission from Warren and Dixie. For Raceland, I took out some details, but this is the care plan that exists in our EMR with Epic. And what's what's important is to know is that Epic has this tool, and this is in what looks like a normal note, but actually, when a child is admitted and there is an encounter now for that patient, this note shows up as a big, huge yellow sticky that actually gets in the way of the rest of the chart. And you actually can't do anything. You can't engage that patient's chart until you've read and scrolled through the entire care plan and acknowledged that you've read it at the bottom. And what that helps with is one, making sure that, for instance, ventilator settings are consistent, that respiratory or pulmonary toileting is consistent, et cetera. Medications are consistent, timing is consistent. And as Dr. Schnell mentioned, there are often added aspects integrated into that note about, again, what matters to you most. What are the goals of care, and what does the child enjoy? Are there certain things, certain caveats we need to be aware of that are beneficial to this child? And we often include in it individuals that need to be notified. So not every child who has complex care, not every endocrinologist and pulmonologist needs to be notified, but sometimes they do. And there are individuals that really enjoy being alerted and want to come back and say hi, and they're near, and that's part of the coordination of care of that particular interval, and then extending that on. And it's important when individuals who know this child well have the opportunity to visit and engage with the ICU team. Um, and this can be crafted in collaboration with a family member. I've done it in the past with a different child where there were in the past before Epic really sort of took over the world, and family members, and many of you might do this, where you have laminated sheets where you come in and say, this is my child, this is the one-liner, this is the 10-liner, this is by system, this is what my child needs, etc. And hand that to, for instance, emergency room physicians who just don't know even what ACTA 2 is, MSMDS, etc. And this helps coordinate care, helps communicate. And this takes the place of that within the EMR, so it's quite universal. Also, with version control, the laminated sheets become problematic because then you have to edit it, the family does, and laminate it, etc. But this is another way to do it, and integrated into the EMR. And one issue is version control within the EMR and making sure that either the P3 or a care provider or a PCP helps maintain the keeps this particular care plan note up to date, because it can change with time. But I've crafted these before on Word, for instance, as a Word document, shared it with a family member, and we've side by side edited every line to make sure it's consistent with the family expected. And then we upload it into Epic, and that becomes the care note, or it becomes the care plan. And that way, the family members are feel secure that the next individual, as Dr. Schnell mentioned, sort of the deja vu moment that occurs over and over again, can be the impact of that, the negative impact of that can be minimized, because an individual who is seeing this patient for the first time can read through the plan that's been carefully crafted with the intensivist care team and family members. In fact, sometimes in these care plans, I've had different sections. For instance, with endocrine, I can extrapolate it from their note, but I sometimes send it to the endocrine team just to verify that, would you want this written in the care plan, or would you want it to be a little bit more vague and say, please call us, instead of just giving this amount of insulin, for instance. That's not the case here, but I'm just saying there are things within certain patients' care plans that fluctuate moment by moment. And so sometimes we just create a skeleton care plan with respect to that particular organ system, for instance. But again, putting the name of the provider that's the primary provider within that subspecialty is often important. So if this is something that you haven't experienced yet, please let us know. We can try to help you find out where that's available, et cetera, or work with your or your care coordinators, et cetera. It should be available.
Okay, I know we have, I want to be mindful of time. Do you want to just say anything quick about
Yeah,
that?
I think we've talked about this in the past Act of Two meetings. It's really important to remember, and this can be integrated into the care plan, for instance, or just these 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 caveats, these aspects of Act of Two patients' sensitive systems that they respond to hemodynamics, cardiopulmonary variability differently than one would expect. And it's good to think about what sedation could do with regards to GI tract, with regards to needing pressors, hypoxia, and what that would do, and that intubation can be prolonged for multiple reasons, PICs, DVTs, blown pupils, being very, very mindful that the slow to respond irises freak a lot of people out, and it's important to convey that you don't need to go rushing to the CT scanner unless you really think that's necessary, and be trying to tease that apart from a true intracerebral accident. Use of sedation and prolonged weaning is a big aspect. Use of antibiotics, cultivating resistant bacteria, and surgical complications leading to tissue loss, et cetera.
And sometimes these things aren't avoidable, right? Sometimes you need sedation, sometimes you need antibiotics, but in situations where you can't avoid needing a medical therapy, just making sure that you have a preemptive plan for all of the things that are going to happen afterwards, right? So do we need to use extra fluids after giving a medicine that's going to make your child's blood pressure low? Like, let's just plan to do that, go ahead and order it, so we're not chasing our tails after things that need to happen, but we know we're going to have consequences. So our sort of leaving thoughts are, you're not in this alone. There are people on your child's medical team that want to help coordinate your care and make sure that your child receives the best care possible. Learn a whole lot from other families. That's why I love this conference, is that there's just like so much lived experience in this room right now. And the what's happened before is the best predictor of what's going to happen next. And so really using this community, pre-coordinate things as much as you can. Ask for care conferences, ask for team huddles, ask for a certain specialist to be on rounds. Just go ahead and anticipate the need for these multidisciplinary discussions. Maybe at scheduled intervals. If your child is in the hospital for a while, maybe you do a family meeting every 2 weeks that just goes on Dr. Mussolino's calendar, and so you know that they're already going to be like reserved and know that that is happening. And then keep track of what your child's body does and how your child's body reacts to certain things, whether that's in your own notebook, or whether you make sure that that experience makes it into the care coordination notes so somebody knows it for next time. Your child's body is also the best predictor of what your child's body is going to do in the future. And although everybody might have the same genetics, we know that every patient is really different in how they react to certain things. And then the most important thing is everything needs to go slow. And the MSMDS is overall very sensitive to medical changes in all different organ systems, all different parts of the body. And the most important thing is to not fix everything at once, to not try more than one thing at a time. And maybe that means that your child needs to be in the hospital a couple of extra days just to make sure that the change was tolerated okay, but it's worth it to go slow.
Well, I agree. And just as Dr. Schnell said, I think the concepts of the P3 and the what matters to you most, care plan, going slow, being mindful of all the different changes and just working together. Some individuals So and sometimes, as Dr. Schnell mentioned, sometimes things change over time. So some things that worked really well 2 years ago don't work well now, and vice versa. We've had some things work really well later. So, but I think the Active 2 community is such a brave and beautiful community, and coordinating and communicating and coming up with game plans. We've seen some incredible innovations come out of this group, both from the scientists, but also from the family members. And it's been a real privilege to work with all of you and Dr. Schnell.
Yeah. Okay, that's all we have. I am here all day today. I didn't talk a ton about what I do, but I'm happy to talk more about that. I talked more about it last time. Yeah, any questions? Yeah.
Yeah, so I'm glad we have multiple providers up here from different hospitals, because I think one of the challenges a lot of families have is they have their local hospitals that they go to, and then they may go to MGH, they may go to a regional facility. And I've noticed a lot of problems, specifically when in the Epic system of the different hospitals, being able to share care plans, share imaging, other things across those platforms. Could you talk a little bit more about, as providers, things that might be going on to help you guys be able to see transparently across the different hospitals, consolidated notes and information?
Yeah, it is very much a challenge. So much so that sometimes I tell the family to call me when they're in the ambulance, and I tell the ambulance to go somewhere else. Um, but that definitely is a challenge. I do think Epic, my experience with Epic is that it's getting better. My team now does have the ability, it automatically pulls in external hospital labs into the place where our labs are. And you can see everything there, but that just happened like a couple of weeks ago. So I do think it's better. One thing that we do, because you're right, if you go to a local hospital, even if they have Epic, this is not going to be at the top of your child's chart there. But I also put the care coordination note into my note so that then they can look at the text of my note and see it. And then we also recommend, like Dr. Carroll said, having a laminated copy of it to have in the car with you, or on your phone or something, in the event that something happens or you're on vacation and end up in a system that doesn't know you. You can also put images in the care coordination note, which is really nice. So I've had physicians that like make anatomy drawings and put it in there so that even if you can't see imaging from the outside, you know what the child's anatomy is like. And you can also put like a single picture of a scan if there's like a really important image, like your child's aorta or something that you want to make sure is there for everybody to see, even if they can't see the scroll through part of the picture. But yeah, I definitely understand the challenge, and I hope that we're figuring out ways to fix it. But
I mean, I think the one that we've had that's been the most critical has been CT scans. Like if somebody goes into a local ER, you want to see what the dilation looks like from the past CT scan, which may not be necessarily available, which forces them to do another CT scan.
yeah.
Yeah.
Um,
Yeah. Oh, go ahead.
No, right, go ahead.
Oh, I just think that, yeah, one of the value add for Epic was that maybe we could be integrated, but they're not entirely integrated. One of the third party software is called Careways, I think, that helps us connect from Epic to Epic. But images are a real issue. I would hope that any individual who lands in an emergency room, for instance, the physicians taking care of your child should be okay with calling wherever you were last and having a conversation. And sometimes, if with your permission, they can share screenshots of CT scans and things like that. For instance, if someone calls and said, we have this patient in our ER, they were just in your PICU. Can you talk to me about this child? A lot of times there's a fellow or someone who is aware of that child's time. But that's all, you're putting those pieces together, and it'd be nice if it was totally seamless, but it's not right now.
Yeah, and I wanna You're on, right? I think I turned it off.
You're on.
Patty was over here. I do have, for the question, I think it's several fold, probably very complex answer, Seth, but one is acute care, so going to an emergency room and going to a visit appointment. So let me address the visit appointment. Usually in the outpatient setting, there's more time to prepare for you're seeing a patient for the first time, or you're changing locations. This is happening for some families, and you're establishing your care. You will have to be providing these physicians with a single document. You can't ask them to review sometimes your entire patient medical records. There are jungles of useless paperwork. It's hard to find information in Epic, believe it or not. It's getting better. One day it will be done for physicians, but at the moment it's not. So be very mindful of having always in your hand your last coordinated care or your PICU discharge, if you were discharged from the hospital. And also, if you have a multidisciplinary team that has seen the patient locally, or a primary doc that knows the disease the best in your child, because some kids are more affected in the brain, some others are more affected in the gut. And then it's that physician that summarizes in their notes kind of the system approach for the disease. So identify these 1-2 notes, have them in PDF. I'm asking everybody here. So you are able to, once you got an appointment with someone and you need to share information about your child, you follow up with an email or a call to that clinic that you're being sent, and make sure the physicians have these documents. Sometimes there are ways online in the systems, depends on your portals, to interact and put these documents. That's the best way for the clinician to quickly introduce itself to the complexity of this disease that is rare enough, that is not necessarily for everybody in their book. So that to me is a very useful thing. We do a big effort. You don't see my notes sometimes for weeks, because we take time to review all the medical records, put the images into the note. You'll see these things that are very scary for parents. I am sorry, but we're doing it because of what Ryan and Seth are talking about. It's very hard to see real images, but one picture for a physician that treats a patient with moyamoya disease says everything. So that is helpful to have. Don't expect the clinician to find this in Epic. It doesn't happen. Okay, it's very hard. I'm saying it as the one looking and spending hours. So that's one tip for the outpatient. And please provide that clinic, if it's a different system where you're most commonly seen, with the CDs, with the images. You have the rights to your medical record anywhere in the world. This applies to Europe and Latin America and Africa and Asia, to get your full medical records out of the system. It's taking more time for some people than others, depends on your hospital, but get your CDs. And I recommend always, whatever your kid is having in the medical system, try to get the images sent to you at some point. So you have your own database and you're able to provide these things when they request them. That's in the outpatient. Those are my tricks. For the acute care, we do this all the time. I think, Ryan, your point of ask the physicians that are seeing your patient, they don't, in an emergency room, they have 15 to 20 minutes to assess the kid and decide what needs to happen. So it's not possible for them to learn about the complexity of the disease and the last things that happen to your kid. And you will be providing this information verbally as much as you can. But I think it works really well to ask the clinicians to get in contact with the provider that knows your patient the most. And if there is an event that needs acute care, it's incredibly helpful to work as teams, and we do it across nations. This is called peer consultation, and we do it because it's an ultra rare condition. In fact, there is now some legislation that is going to enable for rare diseases clinicians across the states in the US to provide care, which was overdue and hopefully continues to progress. But truly speaking, it's you asking them to talk to someone that knows the patient, if it's an acute care. And the other one we've been having a lot across the world is medical surgical interventions. So when there is a surgery upcoming, try not to ask to get in contact with the surgical team and the anesthesia team just a week prior. For us to prepare for a surgery, it usually takes us several weeks to align all the services that we need, pulmonology, anesthesia, critical care. to let them know what we are up against. So if there is a planned surgery, take your time, try to put the teams in contact with your primary MSMDS provider so they can share the knowledge about the disease and what they think would be recommendations to avoid complications that are preventable. And if you are in the emergency room, do what you guys are doing. Just call who you can get called on. Usually a clinician, but ask to be paged or paged through operator of the hospital, the doctor you want to reach. And we, on the spot, most of the time, share the recommendations wherever you are. And you have examples in the room I had to get an appendix removed. I have an aortic dissection. They need to take me to the OR. And we are there, and someone is there. If it's not me, because for whatever reason I'm not around, it's Dr. Lindsay, it's Dr. Ryan, Carroll, and we manage these patients in teams. And a third comment and the last one, when your kids get to be teenagers and they're weighing more than, what is it in pounds? I would say 80 pounds. The care from the adult side starts intertwining, like when you're 12, 14, 15, and you're getting an aortic replacement. It depends on where you are. If you end up, even in the children's hospital, you end up with an adult surgeon. So try to build that communication between the adult and the pediatric. And just to give an example, we take our patients, we're in a common building, so we have the luxury of moving peds to adults with no problem. But if we're gonna take a 12, 14, usually 14 and above, ideally, into an adult ICU after surgery, we do a lengthy preparation with child life involved, with social worker, with the PICU team and the pediatric consultants working with the adult surgeons and critical care doctors. All of that is doable, okay? It's not just us. We've been doing it in South Korea. We've been doing it. So even when we don't even speak the language, these are things that when you transmit a couple of points, the team can discuss, and they just know each other now. When something is happening, who do you need to call and discuss with? And not in the middle of, we have to make a decision, I don't know who to call. Remember, as you guys were highlighting, there are multiple teams switching, so you are the steward of this whole thing. So you've got to build your strategies.
This disease is at least nicely named. So if you need to tell a clinician that doesn't know your child and doesn't know anything about ACTA2 or MSMDS, just saying the words, my child has multisystemic smooth muscle dysfunction syndrome, that's pretty self-explanatory, actually. You really, all you have to say is my child's smooth muscle doesn't work like it's supposed to. And most providers can kind of extrapolate from that what that starts to mean in different organ systems. And so that's at least nice that no one is going to know what ACTA2 is, but you can just say that one sentence and it gets a whole lot across to clinicians about what we need to be thinking about vascular and GI and pulmonary and all the places that have smooth muscle. So whoever named it MSMDS, strong word. All right, thank you guys.
There's another question. One more question, there's time.
I was just gonna make a very general, stupid comment. When you're going to hospitals that have Epic, make sure you sign the release so that one hospital can look at the other hospitals. So say it again, in case that wasn't loud. Just to make sure you sign the release so they can see from one hospital to the other hospital with Epic, because I'll have patients who go to an Epic hospital, but I can't see their notes at all because they didn't sign the release saying that I could, even though we're both on Epic. So just when you register, when you check in, whatever, just say, I need a release so they can see these notes at this other hospital.
Mm-hmm. Thanks, everyone.
Oh, sorry. There's a question in the chat, which Dr. Carroll addressed directly, which was, could we have an example of this care plan reminder? So I think organizationally, ACTA2 Alliance would like to help facilitate that for all of our families. So we'll work offline with Dr. Schnell and Dr. Carroll to create a template and help families to create that one pager to just hand to people. So everyone be on the lookout for that coming up.
Yep.
On that. Thank you.
Thanks, everybody.
Great.
All right, thank you very much.